by our Gloucestershire group. My name's Wendy and I am chair of the Gloucestershire group and also a director for Greener Practice. We're absolutely delighted to have Nuala Hampson as our guest speaker tonight. But before I hand over to Nuala, I just wanted to say a few words about Greener Practice. So Greener Practice is a not-for-profit community interest company enabling primary care to become more environmentally sustainable. And we do this through our network, working in partnership with individuals and organisations that share our values, and through our Greener Practice platform. So if you haven't visited our website, do please take a look. It's a great way to make connections. You can sign up through see your local WhatsApp group and the national special interest groups too. And all this and receiving national and local newsletters and some of the resources are free. So how can we help you? How can the website help you, and how can we help you in your busy GP practice? Well, there are in excess of 50 off-the-shelf QI projects and more resources behind a modest paywall. These can provide excellent evidence for multiple CQC standards and other quality improvement standards too, including medicines optimization and safety, which not only contribute to environmental sustainability, but save you time and money. It also helps to complete many actions in the Green Impact for Health Toolkit, which can be accessed through our website. So Green Impact for Health, if you don't already know about it, is a great framework with a whole team approach to chart your sustainability progress. And a significant proportion of our practices in Gloucestershire have signed up to this and have received awards. So talking about the modest paywall, so these are the levels of membership. So this on the left-hand side is what you get as a free member, and it's a good starting point to see whether you like the platform and what there is there. But then the Network Plus, which is this modest fee of £30 a year, gives you access to all the QI projects and the full suite of resources. And even better, of course, if you can get your organisation to sign up at Network Plus, and the cost there depends on the number of seats you want and the size of your practice, or your ICB or PCN, or any group of practices really, but any level of organisation. So now, the next thing I just want to say to you is that, just to mention that the information that is shared this evening is accurate to the best of our knowledge and is to inform and educate, and it's not substitute for clinical judgment. So I'll hand over to Nuala now for her to tell you more about her amazing care home waste project. It's relevant to all of us in primary care, and particularly to Gloucestershire this year, as we'll be running a funded QI project based on this work. And the final thing to say is do please complete the feedback survey, the QR code at the end. So I'll stop sharing now and I will hand over to Nuala.
Great, thank you very much, Wendy. So I'll just share my slides. If you can let me know when you're able to see those, that would be great.
Yep, that's fine. Yep, we can see.
Okay, so my name's Nuala Hampson. I am a pharmacist by background and I'm a pharmacy lead at the Centre for Sustainable Healthcare. So thanks very much to Wendy for giving me the opportunity this evening to present the project that we undertook last year on medicines waste in care homes. So this was a Q Exchange project funded by the Health Foundation and NHS England. And what we wanted to do in this project was to look at medicines waste, which is a long-standing systems problem, which I know all of the pharmacists in the room will probably be aware of. Nationally, the scale of medicines waste is really quite shocking. So in this project, we wanted to look at the problem through a slightly different lens. Obviously, coming from CSH, we obviously have an environmental sort of focus. So we already know about the cost of medicines waste. We really wanted to look at the other impacts and how we might address these. So we worked with 4 hubs across England, one of which was Gloucestershire, and Chris Skifkins is here this evening to give his sort of experience from the project to sort of look at different aspects of medicines waste in care homes. So why is this important? And I'm sure you already know this. So medicines obviously account for around 20% of the NHS carbon footprint. So it's a really significant aspect in terms of the carbon footprint. In terms of financial costs, medicines waste generally in England cost around £300 million a year, and from care homes specifically around £50 million a year. And these figures are from 2010, so they're quite old now. So the likelihood is actually the figures are probably much higher, given that the prescribing budget has increased year on year within that time. So we already know that there's these really quite significant costs and significant volumes of medicines waste. So what are the other impacts? So obviously we're interested in thinking about the environmental impacts, because when we think about medicines waste and throwing stuff away, we need to remember that there is no away. Waste always has to go somewhere. Pharmaceutical pollution, particularly of waterways, is a really significant problem globally. Specifically in the UK, there was a study done a couple of years ago where they looked at all of the rivers in the national parks in England, and they found all of them polluted with pharmaceuticals, up to 31 different active pharmaceutical ingredients in each river. And when antibiotics are involved, that obviously also then increases the risk of antimicrobial resistance. Worth noting that the majority of waterway pharmaceutical pollution comes from excretion of active pharmaceutical ingredients after medicines have been taken appropriately. But where people are inappropriately disposing of medicines, for example, pouring leftover antibiotics down the sink or toilet, then that obviously has a really significant effect. And with sort of all of this waste sort of washing around the place, the likelihood of it ending up in the waterways obviously is significant. And we also need to think about the packaging. So when we're talking about medicines waste, we tend to focus on the medicines, but medicines, inhalers, devices like insulin pens, etc., they tend to be made of or packaged within really complex plastics, which are not designed for reuse and are really difficult to recycle. So there's a really significant plastic pollution problem linked with medicines use and medicines waste as well. And then the other aspect that we wanted to look at was the sort of social impact of medicines waste. And this was specifically around staff time. This one was really difficult to measure because everybody's too busy to measure what they're doing and to log the time that it takes them to do stuff. But we observed significant wasted staff time across all of the 3 sites. So in each of our 4 hubs, so 1 in Gloucestershire, 1 in Warwickshire and 2 in Somerset, in each of those hubs, we had 3 sites. So we had a care home, we had the GP practice that prescribed for that care home, and we had the community pharmacy that dispensed the medicines for that care home. So that was each hub. And in each of those sites, across all of the hubs, we observed that there was an awful lot of wasted time, which centered around inefficiencies around the medicines pathway and the prescription ordering and review process. So lots of time spent by staff on the phone, chasing things up, querying changes to medicines, having interim orders, so multiple orders from care homes on an almost daily basis, and multiple deliveries. So we found sort of lots of different aspects of interest. So just a kind of quick summary of what we did in our project. We really wanted to focus on the sort of SusQI framework, which is the Sustainability and Quality Improvement framework, which is developed by the Centre for Sustainable Healthcare. But we really wanted to really kind of do a bit of a deep dive into what was going on. So we really focused on the studying the system step, because we wanted to kind of spend that time to try and figure out what the issues were so that we could try and come up with some solutions. So our timeline for the project is listed here. We had kind of a year to do this project because we had funding from the Q Exchange, and that was sort of our timeline that we had to do. A couple of key aspects that I wanted to really draw out. One was educating staff involved on the scale and the impact of medicines waste. So we found that staff were really unaware of the potential impact of medicines waste, or indeed the sort of the scale of medicines waste within their local hub. And they hadn't really thought about what the impacts might be. And we realised that for care home staff who have a lot of mandatory training on medicines, which is required by the CQC, they have lots of training about how to order medicines, how to administer medicines, how to store medicines, but nothing at all on waste medicines, disposal of medicines, how to reduce the waste of medicines. So kind of education was a really key aspect. And then studying the system in detail. So what we got each hub to do was to do some process mapping. So somebody at each of the 3 sites sort of processed mapped their processes around medicines and prescriptions for the care home. So the GP practice, the care home and the community pharmacy. And these ended up being really quite complex process maps because The process is really complex. There's a monthly sort of cycle of ordering where the care home will order sort of all of their regular stuff on a monthly basis. But then we found most care homes on an almost daily basis were then ordering interim items, acute items, stuff they'd run out of, stuff they'd forgotten to put in the monthly order. There were urgent orders, there were non-urgent orders, and each of these had a slightly different process and a slightly different way of being managed. So it was really important that stage of looking at those process maps and then sharing those across the hub. And then the other thing that we had the luxury to do was to spend quite a bit of time on data collection from the medicines waste logs. So all care homes are required to keep a log of all of the medicines that they dispose of. At the moment, these are still largely handwritten logs. So kind of exploring and analysing those can be challenging. We had the luxury of some time, and we had some fabulous volunteers at CSH who transcribed basically photographs of handwritten waste log pages into spreadsheets that we were then able to manipulate. But that was sort of really insightful, what we were able to see then in terms of what was going on with the medicines waste, what people were throwing out and why, and that differed quite widely across the different homes. And then fundamental to the success of the improvements was the development of a working relationship between key staff at the care home, the pharmacy and the GP practice. So after we had sort of collected all our data and we'd done some number crunching and analysis, we then presented it back to each individual hub where we had a workshop aimed at co-creating ideas. So we kind of identified all the issues and the challenges, and then the workshop was to get them together to kind of come up with some solutions to the problems. And what we found in this was an online workshop that I was facilitating remotely. In that online workshop was often the first time those key people from that hub had actually spoken to each other, even though they were all within a mile or two of each other down the road. And once you kind of got them in a room together and they had looked at each other's process maps and they understood what was going on, I just basically let them at it, and they were able to sort of figure out sort of what the challenges were and why they were challenges and what they might be able to do to change them. So actually starting to develop that relationship of the key people at each of those three sites was absolutely critical to everything else. And as we went through the project, we recognized that actually maintaining those relationships, was also challenging. All of those sites are very busy, patient-facing, pressured sites. Everybody's busy. But when people knew who they were talking to at the care home or the GP practice or whatever, it was easier to have those, difficult conversations or to deal with problems or whatever it was. And staff turnover can also be quite an issue. So sort of continuity can be a problem. But if you do one thing sort of around care homes is trying to establish those relationships between the key people across the sites, that just really facilitates everything else, to be honest. Excuse me. So we did quite a bit of data collection and analysis. We were able to, because we kind of did a deep dive into the waste logs, we were able to then sort of give each hub some detailed information about the content of their waste and what they were throwing away, which they were able to go away and sort of kind of analyze in a little bit more detail. But what we were interested really was in the sort of the systems and the processes and what we could change. So kind of top level in terms of what we found, the medicines waste aligned really with the national figures that I shared with you earlier. On average, the medicines waste was equivalent to around about £125 per bed in each care home. We had a range of different care homes of different sizes and types, so we just did an average. That it was equivalent to around about 3 tons of CO2, which is the equivalent to driving over 9,000 miles in a petrol car, or over 300 GP appointments, which is really significant. On average, 46 doses were discarded every day on average in each care home. So that's A, quite a lot of doses, and then B, quite a lot of time. So the kind of the most successful aspect of measuring staff time was getting the staff in the care homes who were disposing of medicines to log the time spent just disposing the medicines, not any other step of the medicines pathway. And we worked out that around 3 hours per week of staff time in every home was spent just logging the medicines that were then thrown in the bin. So that's really quite significant. Just a sort of few sort of highlighted points from the sort of the kind of looking at the medicines waste logs. There wasn't really a trend because every home was quite different, but I guess some sort of headlines were there were some really high cost items that we were questioning, well, why did these need to be wasted in the first place? So monoclonal antibodies, 10 injections cost over £6,000. So for that particular home, that was like 60% of their entire cost of their medicines waste. But we were like asking the question, why did you have 10 injections of a hospital prescribed items that the patient didn't need? High volume of low cost items. So we saw, you know, Laxidos sachets being chucked out by the box load, endless bottles of 40-sip, lots of paracetamol liquid, which in itself is not that expensive, but when you start chucking out bottles and bottles of it, then it can become quite expensive. End-of-life medicines, analgesics, and laxatives were commonly in the sort of top 5 most commonly disposed of items. The cost of liquid medicines waste tended to be higher on cost per dose than sort of tablets or capsules. And there were some really high cost items in there where people had got specials liquids. So I remember one was a bottle of thyroxine liquid that was equivalent to about £300. And common reasons for the waste, why medicines were disposed of, were often refusal, medicines were discontinued, the patient had died, or there was excess stock. And we kind of queried that excess stock. What did that mean? And in one home, that meant that at the end of every month, they just sent everything back, chucked it all out, and ordered it all again. So lots of things going on there. So key findings were, first of all, there's no accountability for medicines waste. So nobody's really measuring it. Nobody's looking for it. There's no targets. There's no consequences. And how people manage their medicines waste is variable in the care homes. We found multiple factors drive the medicines waste. And we found that wasteful and unnecessary activity was really common across the 3 sites in the pathway, adding to staff workload and staff stress, and potentially causing delays in medicines getting to patients. So in terms of accountability, we found that management of waste was really variable, confusing, and time consuming, and that staff sort of weren't always aware about what they should be doing. We found even within the same home where they had different units that what they were putting into their medicines waste differed even within an individual home. So in some homes, staff were actually popping tablets out of the blister, which is kind of one extreme. And at the other extreme, in another home, they were throwing out the whole cardboard box, patient information leaflet, blister, everything was going into the medicines waste bin. So bearing in mind that all medicines waste is sent for incineration, if you're putting stuff in there that doesn't need to go in there, as well as it costing more in terms of the medicines waste, it obviously also has a higher environmental impact because that waste will be incinerated and will cause sort of local air pollution wherever that incineration plant is. So the medicines waste is not actively managed. So the care homes keep these medicines waste logs because they have to for CQC, but nobody ever looks at them. So nobody reviews them. Nobody kind of knows what's going on. Nobody looks in the medicines waste bin. So when we were chatting about this with the Sheffield group last week, we came up with the Show Me Your Medicines Waste as a bit of a sort of development of Deb Gompertz's Show Me Your Medicines, but actually going and having a look at what are they throwing in their medicines waste can be really very insightful. And getting somebody to just keep an eye on the medicines waste log, then you can spot trends and then sort of maybe think about, well, why is this happening? Or, you know, why do we have all of those really high cost hospital items that we shouldn't really have? As I said, the staff hadn't received any training on the medicines waste. And a really key thing is that prescribers never see the medicines waste. So prescribers just kind of are not aware of it. They never see it. It's not measured. There's no sort of national monitoring or anything else. So as part of this project, we took lots of photographs of the medicines waste, and we really encouraged the care homes to share that with both the GP practices and the community pharmacies. So nursing homes have to pay to dispose of their own medicines waste. So their medicines waste will be collected directly from the nursing home. So the pharmacies who were supplying the nursing homes weren't necessarily aware of the level of waste coming out of those homes. For residential homes, they return their medicines waste to the community pharmacy for disposal through the community pharmacy service. So sort of different services happening as well. So for the nursing homes, there was a financial incentive there to reduce the amount of their medicines waste as well. And one of the homes was able to do that by just simply stopping putting the cardboard boxes into the medicines waste and just taking the blister out and putting the blister in. They were able to reduce their monthly medicines waste bins from 3 to 2 just by that simple change. So sort of suggestions in terms of sort of addressing these things, we really encourage care homes to explore the data, looking for trends and anomalies. For nursing homes, looking at how many bins are you paying for and are you putting stuff in the bin that doesn't need to go in there. So we also found things like non-medicinal items like emollients, sip feeds being put in the medicines waste bin that didn't need to be put in the medicines waste bin. So having a look is really insightful. As I said, staff received no training on medicines waste. So one of our key outputs from our project was to develop a 15-minute training video. And this is targeted at staff in care homes, GP practices and community pharmacy who are sort of dealing with medicines in the care home pathway. And it's really just a quick overview of the sort of environmental impact of medicines, the issue of medicines waste, and some sort of tips on how to reduce medicines waste in care homes. So I think that's going to be included as part of your upcoming quip on medicines waste, and we really encourage, that's freely available on the website and the QR code is there in the corner, and I'll share that again at the end. Really encourage you to share this in your areas and really widely, because we want to share this as widely as we can. And then showing the prescribers the medicines waste by maybe, you know, sending them the pictures or putting it in if there's local prescribing newsletters or whatever, but really just trying to raise awareness of the issue so people think about it a bit more. So this was one of the examples of one of the projects. This was the team from Warwickshire, and they were doing different things basically with their medicines waste, putting different things into their medicines waste bin. So basically they reviewed their policy in the care home about what needed to go into the medicines waste bin, and they updated their procedures to ensure that they removed packaging where that was appropriate, and they were, as I said, able to reduce the volume of medicines waste from 3 bins down to 2. And it also helped staff to feel a little bit more confident about, you know, what they should and should not be doing. One possible negative social impact of that was it took a bit more time. Obviously, just chucking the whole box in is quicker than taking the blister out, putting the cardboard box in recycling. Although sadly, what we found was most care homes didn't have access to any sort of recycling, even basic paper and cardboard recycling. So balancing the time with, you know, the benefits. So we also found multiple factors driving medicines waste. First of all, sort of activities that were creating waste, and these often were sort of from the care home side of things. So over ordering medicines, not syncing interim orders with the monthly cycle. So care homes have this sort of very rigid monthly cycle, and everything sort of focuses around the monthly cycle. And then if anything is ordered or started or changed outside of that, it needs to be ordered separately. And care homes would just order 28 days. So then that item is constantly out of sync, or they have too much, and it's a continuous sort of interim extra order that's being done outside of the monthly cycle, instead of trying to take the time to align it and fit it in with the monthly cycle. So kind of suggestions around this for the care home were to try and align their interim orders, because these interim orders just created so much work for everybody, because that's another prescription that needs to be ordered from the general practice and then get sent to the community pharmacy. And what we found for the pharmacies with these interim orders were really driving very high levels of medicines delivery, which I'll come to in a minute, which turned out to be one of the carbon hotspots of this pathway. So really encouraging homes to only order what they need. They tend to not really think about the cost of medicines because it doesn't really affect them. And because nobody's monitoring that waste, then people just order whatever they think they need whenever without really thinking about it. And we also found that there was lots of duplicate ordering going on. So in one care home, the weekend staff were being really super organized and helpful and sort of going through and ordering everything that was needed. And then on Monday morning, the regular staff were ringing up the pharmacy going, where's our prescription? And they didn't really have a concept of the time that these things would take. And then in some cases, they were reordering stuff that had already been ordered because they hadn't got it yet. So you can see how sort of all of this sort of confusion and queries would sort of just escalate. So something as simple as the care home understanding how long it takes for a prescription to be dispensed and delivered, understanding pharmacy cutoff time. So if you're ordering an urgent prescription, what time do you need to order it by from the pharmacy in order for them to be able to deliver it that day or the next day or whatever. For prescribers going into care homes, it was really helpful for them to understand this process and the monthly ordering cycle. And for example, if they're prescribing a new medicine, to be able to say, this is not urgent, it can wait until the next cycle, or this is urgent, we need it today, or this is relatively urgent, but it's fine in the next week. So sort of giving a clear indication of how urgent medication was, then help the care home to sort of communicate that to the community pharmacy. Because what we found in one community pharmacy is they were treating all of their interim orders as urgent, when many of them weren't. They were just a new prescription that had happened on a ward round or when a GP came out to visit. Wasn't urgent, but it was interim. So just a simple thing like that, the prescribers sort of asking that and being really clear about how urgent things are. And then making sure pharmacy are made aware if it changes. So particularly after weekly ward rounds, lots of changes were made to medicines. And often we found the community pharmacy was out of the loop. So then they'd get these prescriptions where all the doses had changed, but nobody had told them why. So then they were kind of going back to query them and follow up and check. And again, that caused more work, more delays, everybody feeling a bit frustrated, really. So for the pharmacy, it was really empowering them. And again, sort of seeing the process across the 3 sites really helped them to see that actually, yes, they did need to challenge things. And they did need to question, is this actually urgent? And in doing that, they were able to sort of streamline their processes a little bit more. We also found a throwaway culture generally, and again, this is because the medicines waste is not really monitored. In one home, we found a care home, very well intentioned, putting unnecessary expiry dates on things. So for example, they were throwing out all of their inhalers after 28 days after they were opened, which is completely unnecessary. Now, there are recommended expiry dates for creams that are available from Prescript, but again, sometimes they had much shorter expiry dates. So they were throwing stuff out that was perfectly usable, that the patient was still using and ordering it again. As I've mentioned, some care homes were returning everything at the end of every month. And then depending on the dispensing system, so one of the care homes had just moved away from a monitored dosage system, and they had found that massively reduced their amount of waste. One of the homes or one of the community pharmacies in the project was doing robot dispensing into sort of individual doses into little plastic pouches. So obviously, if they weren't given for any reason, they were disposed of. They couldn't be sort of reused. And then there was also this fear from care home staff of overstocking, because it's sort of one of the requirements of the CQC that care homes don't overstock medicines. So one of the matrons, that was the reason she gave me for getting rid of everything at the end of every month, because she was worried about CQC coming in and saying that was a problem. So again, we kind of talked about avoiding that sort of waste of medicines, following the guidance that there is on waste segregation, and also looking at policies that are there already to support reduction in medicines waste. So things like bulk prescribing and homely remedies, which may or may not be appropriate for individual homes, depending on their setup. For prescribers, being mindful of the quantities prescribed and where you are in that monthly order, and avoiding unnecessary prescribing, and SIP fees came up as one of those things that was wasted on quite a large scale, and for pharmacies to get engaged in that conversation and challenge any sort of excessive ordering. So we noted that the medicines pathway is really complex, that communication between the sites and sometimes even within the sites is difficult because these people never see each other. They're at their own geographically remote sites, and there was a lack of understanding of the processes between the sites, which tended to kind of contribute to these problems. And this resulted in wasted time, wasted medicine, and wasteful activity. So in terms of the communication, no key person was identified at each site. So when we said, we want a key person from the medicines pathway, they were going, oh, well, who's that? And they had to kind of figure it out and think about it. So nobody sort of had that role as, I'm the key person for the care home medicines in the GP practice. Community pharmacy did tend to, and the care home, it tended to be a few different people. We found that generally there wasn't agreed communication methods between those 3 sites, and that was something that we did as some of the improvement projects. Where there was communication, it tended to be between the care home and the GP practice, and the community pharmacist was left out and was then sort of chasing afterwards, trying to figure out why changes had been made. And we found in really big care homes with multiple units that there could be internal communications as well as kind of external communication issues. So we found in one care home, each unit was ordering separately to the GP practice and doing it in a different way and not kind of joining it up. And then this lack of awareness of these processes, so the monthly cycle, cut-off times, also ways of ordering. So some care homes weren't aware of things like proxy ordering or online ordering of medicines, which could make things much more simple. So kind of raising awareness of those was really important. So some key activities that some of the sites undertook. One was for the care home to get a generic nhs.net email address, and then to have a secure email loop between the GP practice, the care home and community pharmacy to communicate about medicines orders, changes to prescriptions, all of those sorts of things. Another site got the pharmacy technician at the GP practice to undertake a weekly phone call to the care home, and they timed this around the weekly ward round so that they could troubleshoot and proactively address sort of queries and sort out things around sort of medicines requests and quantities and that sort of thing, and just deal with it all in one go rather than that being sort of dripped through gradually over the week from the care home to the GP practice. And having that really clear and timely communication after the weekly ward round was really helpful for everybody if everybody was clear on what changes had been made and how urgent they needed to be. So that's sort of enabling the communication between the sites understanding the processes at the other sites and how what they did impacted processes at other sites, and then trying to develop that relationship of getting the three of them to work together, because everybody's working really hard in all of these sites, you know, to achieve the same thing, which is to get the medicines to the patient safely. So it just needed a little bit more kind of joined up thinking. And this was another example from Warwickshire. So this was a really large care home and an online community pharmacy, which was around about 20 miles away. And the community pharmacy was doing 3 deliveries every single day to this care home because there were so many interim prescriptions. So the first 2 deliveries were part of a sort of a much wider sort of delivery where they went to about 20 different sites. But the last delivery of the day was always a kind of last minute, oh, the care home needs this stuff, and it was straight to the care home and back again. So the carbon footprint of that journey was owned entirely by the care home, if you like. So by improving their communication and getting a more efficient system and streamlining those orders, they were able to lose that final delivery of the day, which reduced their carbon footprint by over 5,000 kilos. So in this particular case, the carbon footprint of the medicines deliveries was higher than the carbon footprint of the medicines themselves. Which was just kind of blew my mind. So they were able to reduce that by around about 90% by losing that last dedicated delivery of the day. And that was Team A, who had a really big drop in their carbon footprint. Team D was the Gloucestershire team. Actually, they had a much smaller carbon footprint to start with. They were doing around 4 deliveries a week and were able to reduce it down to 3 deliveries a week, which again helped to reduce the carbon footprint of their transport emissions. Obviously, save the community pharmacy time for driver time and also save on fuel costs. This was one of the examples from Gloucestershire. So in this one, they figured out that the GP practice getting their patients on the system so scripts could be ordered electronically really helped the care home and the community pharmacy. So that sort of initial process of getting those care home staff onto their system, if they were able to do that, then that saved a lot of time and effort because paper prescriptions were much less efficient and were getting lost and were kind of generating lots of queries. In this case, the care home were also streamlining their stock management and their medicines ordering system, and the community pharmacy in this case were empowered to question things. So they started not treating everything as urgent and sort of asking the care home, well, you know, how urgent is this? And again, then they were able to reduce their deliveries from 4 a week down to 3 a week, which again sort of reduced their carbon footprint and their costs. But in this one really empowered the staff at all 3 sites to kind of be more engaged in the process and sort of start building up develop that communication links. So this was the pharmacy technician at the Gloucestershire site. Unfortunately, she can't join us this evening, but her learning from this was she had no idea of the extent of medicines waste because they were dealing with the nursing homes, so they didn't see it. That not everything that comes from, not every request is urgent, and that communication was really key. The challenges she noted was that this took time, and that actually kind of keeping that communication going actually required quite a bit of work and effort. But they were able to see successes in terms of reduction of their weekly deliveries, improving their communication, having more streamlined prescription ordering, and having more realistic expectations. So less cranky phone calls from the care home asking, where is our prescription, which was nice. And then we did a brief staff survey across all the staff, and what we found generally that staff really liked the fact that they were getting to know the people at the other sites. They also learned a lot about the medicines waste and the environmental impact, but they also recognise there's still a lot of work to be done in sort of building up those working relationships and keeping them going. So this is just a summary of sort of some of the key sort of impacts that we noted, which I've kind of talked through all of those now. I'm not going to talk through this slide in detail, but this kind of goes through a few more of the kind of change ideas that the different sites undertook. So I'm sure Wendy will be sharing these slides later, so you can have a look at this in a bit more detail. And if you go to the project page on the CSH website, all of the detailed project reports and little project templates are there. So a few key recommendations. One is for everybody to understand the medicines pathway process at each site, how they interconnect and how they can work together, creating those direct, secure communication links and develop working relationships. And the QR code there is advice from the NHS on how care homes can get a generic email address, because that seemed to be a challenge for some of them, but there is guidance on that. And training on medicines waste and its impact for all staff. So referring people back to our screencast. For care home staff, really taking a more active role in managing that medicines waste, thinking about what policies they might be able to put into place in order to sort of help them, and proxy access, where the care home can then take on responsibility for ordering a patient's medicines online on their behalf, seems to be a really efficient way forward. And then using existing guidance to review how they dispose of their medicines waste. And for pharmacy staff, really ensuring you're in the communication loop is the key thing, and then looking at your medicines deliveries and thinking about how you might be able to streamline those to help save time and money, and also reduce the carbon footprint of those deliveries. So in terms of what's next, one of the things that came up in this project that there was a lot of waste of SIP feeds. So some of the hubs that we worked with, there was no prescribing of SIP feeds in the care homes at all. That was a local policy because legally the care homes are required to meet the dietary requirements of its residents. But in ones where SIP feeds were prescribed, we saw, for example, in one case, 209 bottles of SIP feeds being thrown out in one go because the patient didn't like the taste of them. And what we found was that actually nobody really knows what the best way of disposing of SIP feeds is. They don't need to go in the medicines waste, but should you pour them down the sink, there's not good data on what impact that might be having in terms of eutrophication of water systems. So we did a little sort of spin-off project where we got some of our volunteers to ring up all the SIP feed companies and ask for advice about disposal. And we wrote an article about this in the Pharmaceutical Journal, because what we found was that guidance was largely lacking. So that's a really significant issue. And that's just the QR code again for our project page. So you'll find on there the project report in detail, all of the projects that the different sites did, and that screencast, which we really encourage you to share. So thank you very much for your time. I'm going to share as well this QR code, which Wendy's asked me to share, which is just for a bit of feedback on this evening's session. So we hopefully got lots of time for some questions.